Hello again. So I'll try not to repeat too much of what the previous speakers have presented. I formulated a presentation that goes a little bit by questions, so let's see how that goes. So the first question is very simple. What happened to bone marrow transplants since imatinib? There we go. Yeah, and you can see here, this was Sergio's paper several years ago, and the numbers went dramatically down. And the second thing is also the disease stage shift, as you can imagine, to more advanced diseases. So these are two trends that have been with us now. So without this success with tyrosine kinase inhibitors, where are we now? So there are two things, obviously. One is very simple. When do you transplant, right? I mean, I'm frequently asked the question, when do you transplant if there is no social or financial support for Tiki Eyes, which is a tough question. I'm unaware of clear-cut financial studies that show that transplanting patients is better than TKI financially. But at least in Brazil, where I'm from, these discussions are very common, and they seem to have some data suggesting that transplanting still makes financial sense in terms of the socialized medical system. So I don't know the answer to that. And then the second question, which I don't know the answer neither, is how do we put in the scheme of things cord blood and haploidentical transplants for CML? So these are all working ongoing, right? So you saw, I'm not going to elaborate too much on this, but I think the first concept is when do we consider patients failing, right? So I'm going to skip this because Dr. Jabbour has already, and these are his slides anyways. But remember, the definitions of response from the Europeans, I'm not going to, later folks can use these slides I just listed here. This is just the European definitions of response. I'm not going to elaborate on that. But this is important to remember. So if we are to consider somebody for transplant, when do you say, well, something is not going right? So you have here a few definitions, be that at 3 months or 6 months, as Dr. Jabbour is postulating, and I agree with you, 3 months, it's pretty draconian. And, but these are landmarks to remind us, just because the patient is comfortably taking a pill, doesn't mean necessarily that's going to prolong his or her life. So this is important to remember. And these are, again, these definitions, so you folks, we don't have to go through this too much. And as is, the NCCN guidelines also follow this landmark thing at 3 months. So let me skip this. We don't have to talk too much about this. Now, allotransplant. So why not transplant everybody, right? Well, because there is treatment-related mortality. I mean, don't need to tell you that. Another concept, traditionally at least, is that the more advanced the disease, the less you get out of allogeneic transplant. So far, nothing new there. And it's amazing to me that even today, the EBMT risk score still works. You see this covariates that you see here stand the test of time. You can predict a lot what's going to happen with transplant, at least the expectations of risk based on that score, which again does not take into account modern HLA typing and alternative donors, right? I mean, it keeps going back to where do we put here patients who have donors who are not exactly fully matched. But be that what it may, we should have the same way that we have the failure in our mind for Tiki Eyes, we have to have these curves in our mind, because that's what the patients are going to have to think about. The third thing you have to remember is GVHD is not pleasant, right? So life with GVHD is not exactly normal life. So how do you weight those things, right? This is, again, a fairly large series of transplants historically reported to the registry. You can see here met sibling donors in yellow, and the other types of donors there. The more mismatches you have, the curves go down. As a rule of thumb, always remember, imaginary-related donor transplants or otherwise, not haploidentical transplants, 10%, 15% more mortality with more mismatches. That's a pretty effective rule of thumb to have in mind. So what do we have out there regarding haplus and cords? Not surprisingly, China is leading the way with haploidentical transplants in CML. This is just one of the papers coming out of Beijing. And pretty remarkable numbers, as you see down there. Chronic phase patients, 70+% survival, chronic phase, second chronic phase, 80-something%. So clearly indicating that haploidentical transplants have a role, although we quite don't know yet where. And same here, this is Stefan Churia at MD Anderson, pretty much confirming the Chinese data in a small group of patients. You can see these are all advanced patients, actually, that were mostly in second chronic phase, but pretty advanced patients with a pretty solid long-term survival. So CML seem to agree with haploidentical transplants. What about cord blood? Before I get to cord blood, this is just to compare. You see, you compare this curve, if you can see it, with this curve, which is also transplants at MD Anderson that, from my time there, I guess, that were done after patients having had lymphoid or myeloid blast crisis. So these are second chronic phase. And you see, these are sibling or unrelated donors. So very similar survival to the haploidentical transplants. Not randomized at all. So now, cord blood. Cord blood got a bad reputation with CML. Initially, there were several cases of engraftment failure. And the use in the United States has decreased. We write protocols for cord blood that exclude CML, right? I mean, very often our protocols exclude CML, which not so sure makes sense. So this, again, is another paper from China that basically compares 20 patients in cord blood versus sibling donors. And again shows, if you go down the last line there, you see a very solid leukemia-free survival using umbilical cord blood. So suggesting that there may be a role. And there is also this Spanish paper that single unit, 26 patients, and you can see down here, 0 relapses, and again, 50% leukemia-free survival. So suggesting in small series that cord blood may actually have a role, contrary to what everybody expected in the beginning. How do you compare these things? There is no way to compare. This is just the data that's out there. So now, another question. Do the Tiki Eyes influence transplant? Meaning more toxicity or something like that? I don't think there is. Elias here has shown this way, 10 years ago, that you can use these drugs and they do not jeopardize transplant. What about the infamous T315I mutation? So the question is, does this type of mutation influence graft versus leukemia effect? Apparently, it does not. It does, however, matter if you evolve from chronic phase to accelerated phase or blast phase, then your outcome is obviously worse. So this is, again, we did this, when was this? 5-6 years ago, right? So, 2011 published, I guess. So what you see here, basically, patients who had, we ordered tests to look for kinase domain mutations. So the ones in black, we didn't find them. And the ones in dotted line are the ones who had a defined mutation. And they seem to do slightly worse. However, when you adjust that for disease stage, they didn't. So this is actually still one of the few papers like this out there with transplant. Now, how do you compare those results now with ponatinib, bosutinib, homocysteine? I don't know. You saw Dr. Jabour's results. So you have to think about that, and there is no answer, clear-cut answer, with this third or fourth line of tyrosine kinase inhibitors versus transplant. Now, a brief word on after transplant monitoring. I picked one a paper here just as a word of caution. You see here, these are basically historic experience, patients who had RT-PCR after transplant. And the message is fluctuations will occur even after allogeneic transplant. And you should not overreact to them. You see here, they calculated a specificity for an elevated BCR-ABL of 19% and a very low positive predictive value for actual relapse of 12%. Message, be careful with your DLIs because you may jeopardize the patient's health and not be curing anything. What about this? This is another paper, I believe, is it China's? I forgot the institution now, in which discuss a little bit what to do after transplant. And these are patients who relapsed and they were given either imatinib or DLI, suggesting that the Tiki Eyes suffices and you should avoid DLI, which is intriguing. Got to remember, however, that at least in our experience now, these patients are coming to transplant, they're failing 4 TKIs, so I'm not so sure what TKI you're going to give them, so now that they failed everything. So, but that's this publication here. So what we have, folks discussed this a lot. This is actually a slide that I copied from Dr. Jabbour here. And I think for the older patients, the idea of postponing transplant is very clear now in my mind. For those who had advanced disease, it's obviously a no-brainer to consider transplant. And the discussion falls, obviously, what to do with the failures that remain in chronic phase. And I think it's reasonable to say that transplants are being done later and later and later. Again, with the financial considerations that I think we have to adapt to each of our countries, right? What about this? I didn't discuss at all, but my bias is definitely if you're going to transplant, you have to use an IV busulfan-based regimen. Stem cell source, the discussions about peripheral blood versus bone marrow do apply. We don't have time for that. Same for cord blood and haplo. There are reasonable considerations to have. Now, at the end of the day, your goal is obviously the same, right? I mean, you want people in cytogenetic remissions that will remain like that with minimal toxicity. And that's that. That's not my talk, though. Who's that? You again.
Well, no, it's a mistake. Well, thank you so much.
Thank you.
I invite the